Did you know? Let's go.
You've waited all week.
Every week, we continue to learn how to achieve a better back and ultimately better health.
Live in the WIKB studios, this is Dr. Larry.
Well, thank you for hitting the flex capacitor read. Hello again, everybody. Okay, let's get it started. Well, as you know, every show builds on the next. Every week, we continue to learn how to achieve a better back and ultimately better health. Now, in case any of you missed it, last week we talked about pain. It was an important week to be tuned in because we learned and defined about what a pain management physician can do for you because, let's face it, it was another great interview. So, here it is again. Pain. I don't care if your name is Bruce Wayne, John Wayne, or Wayne Gretzky, or if you're an athlete, superhuman, or an average guy named Newman, or a gal named Sally or Susan. If you've lived long enough, you've experienced some type of spine pain. And as you know, there are countless ads for pills, potions, lotions, all geared to treat your back or neck. Some are legit, and well, some are just a little weird. However, when spine pain becomes bad enough to seek a pro, you'll want the one that can find the spot, hit the target, and score the goal. So if you have spine pain from conditions like arthritis, pinched nerves, or bone spurs, then pay close attention to the highlights of our last week and this week's guest. He's a practicing physician and board certified in a specialized field. In addition, he's trained in several medical procedures you are familiar with, like steroid injections in the spine and more, which was and will be the main focus of our show last week and part 2 coming up today. So for the sake of simplicity, I called the segment and mini-series Ask the Specialist. So he's originally from Minnesota, but his wife, a neurologist, is from the Green Bay area, and they decided to live there. No worries, he's a Packer fan. Also, he's a big fan of taking a whole person approach to pain medicine, meaning Dr. Bruhnding is a board-certified doctor of osteopathic medicine and a physician that views patients, quote, through that lens. This is a very important differentiator for how he approaches pain management and pain medicine. So let's define again what a DO is directly from the source, the American Osteopathic Association. In big type, right in front of their webpage is, what is a DO? Now, I get this question quite a bit as well, so let's define it. Doctors of osteopathic medicine use a unique, and here's this phrase again, whole person approach to help prevent illness and injury. Accounting for approximately 11% of all physicians in the United States, doctors of osteopathic medicine, or DOs for short, bring a unique patient-centered approach to every specialty across the full spectrum of medicine. They are trained to listen and partner with their patients to help them get healthy and stay well. DOs practice in all medical specialties, including primary care, pediatrics, OBGYN, emergency medicine, psychiatry, and surgery, and more. Moreover, DOs hold some of the most prominent positions in medicine today, and they are on the NASA medical team, Olympic athletes, and serve in the United States at various capacities. From the first days of medical school, DOs are trained to look beyond symptoms to understand how lifestyle and environmental factors impact your well-being. They practice medicine according to the latest science and technology, but also consider options to complement pharmaceuticals and surgery. And I think as you're hearing this definition start to materialize, these are some of the important attributes that they have. Now, as part of their education, DOs receive special training, and this is kind of where I'm bringing this out as well too, in the musculoskeletal system. That's your body's interconnected system of nerves, muscles, and bones. By combining this knowledge with the latest advances, they offer patients the most comprehensive care available today. So why did I put emphasis on this both last week and coming up this week? From a public health standpoint, I want you to understand the difference because the lines have gotten blurred in present day. However, as been famously framed by many unnamed, the further we look into history, the more we can see the present day and future. So listen to this from clevelandclinic.org. Becoming an MD versus a DO. So the development of the MD and DO degrees follows the history of medical education in the U.S. The first medical schools, which opened in the mid-1700s, which doesn't really seem like that long ago, originally offered a Bachelor of Medicine, but quickly developed the Doctor of Medicine, or MD degree. A physician, Andrew Taylor Still, who was an MD, established the first DO training program in 1892. Dr. Still's philosophy about medicine changed after serving in the Civil War and experiencing the deaths of 3 of his children from spinal meningitis. He believed traditional medicine was ineffective, so over many years he developed the concept of osteopathic medicine, which is today going strong. However, as it goes, the lines have gotten blurred, as I said. So in between this interview last week, and I cruised and perused through the Doctor of Osteopathic Medicine website, some of their peer-reviewed journals, and I kind of looked over a few articles from the Journal of Osteopathic Medicine, and yes, it is a philosophical tenets and concepts that are woven into the DNA and training for these DOs. However, as quoting back from the Cleveland Clinic article on this topic, in addition to the philosophical emphasis on patient care, the main difference between MD and DO programs is that DOs receive 200 hours of training in osteopathic manipulative medicine, and this training is in addition to the regular classes. So that's what came out in the interview. I wanted to spend time on this to review this for that reason, because this week it's heavily focused on the treatment and care. So consider doctors like Dr. Bruhnding when assembling your team of specialists. Yes, specialty is important. However, it makes sense to understand the unique skills and their talents, just like a sports team does when they're recruiting, to create a winning team of healthcare professionals for your care. And when it comes to picking doctors, you need to pick the team that wins. You can do it, but also understanding the differences, their skill sets, etc. So that was some of the highlights and focus of our 1 hour show last week. However, if you missed the entire show, want to be more in the know, then log on to my website, drlarryradio.com, hit the sponsor button, follow the links to become an official sponsor of the show today. That's been uploaded now, which you can listen to at your leisure. So here's the final point. If you're looking for a specialist in pain, just remember to pick the right team to win the game. Now, beyond that, in addition to the DO in the know, last week we learned a simple self-test for ulnar nerve entrapment. It was another Dr. Larry cool tool. You can call my office for a freebie reminder just in case you're in need of a retip or a tip up. And so that was last week. Hi-ya. Now today, we'll forget that monologue for a moment and keep remembering those mandatory communication skills all doctors must have, which are inquisitive listening and staying positive. Also applies to parenting as well. Again, it often means the difference between sick and well. Also, it's another month of the year, so let's keep our legs in gear. So in our tip and trick segment today, we're going to learn a simple self-check for varicose veins. And of course, you, Rito Dorito, are calling it out right from the broadcast booth while we crank up the tunes and I hit the center stage for the demo. However, before all that, in order to have good health, you don't need a lot of wealth. So let's flex our forebrain and put some knowledge to the game, because today we're heading into part 2 of our interview with Dr. Paul Bruhnding, board certified in both pain medicine, physical medicine, and rehabilitation. Hit it, Pearl.
Dr. Larry brings you another segment of Did You Know?
So you heard him infuse both clinically what is necessary and what insurance requires to deduce how to approach treatments from pain from arthritis and how it affects nerves. From the Mayo Clinic System.org, we're going to jump into sensory nerve pain here and how that relates to your pain in just a second. But let's hear part of the interview first. Roll it. You could pick one condition, let's say, just off the top of your head, and something that you provide if conservative therapy isn't working.
Absolutely, yeah. So conservative therapy to me means that therapy, chiropractor, NSAIDs like ibuprofen, even muscle relaxants, things like that. But if arthritis pain continues to be refractory to all that, usually after a solid 4 to 6 to 8 weeks of treatment, then one of the things that we can do, it's very well described, it'd be called a radiofrequency ablation, or RFA, or sometimes called an ablation, or even a rhizotomy. And all those words are long, but the long story short is that the arthritis seems to be symptomatic in either the neck or the low back. It can be done in the mid back as well, but that's not nearly as common. But let's say for the neck, so the arthritis is symptomatic, and we need to figure out and make a hypothesis and then try to prove that. And so the thought is these couple, 2 or 3 areas of arthritis are symptomatic. So under X-ray, I can do an injection where I put in a little bit of contrast dye right next to that joint, make sure that I'm right where I need to be and not in a blood vessel or anywhere else that would take away the medicine. And then you just put in a little bit of Novocain next to those arthritis nerves and see if that pain improves for 2 or 3 hours. And if it does, you actually, from an insurance standpoint, have to prove it again 2 weeks later by doing the identical test. But if both of those go well and alleviate the pain for 2 or 3 hours, then the third and final procedure is called a radiofrequency ablation, and that's very similar to putting a needle 2 or 3 next to those arthritis spots. And instead of just numbing the area, you can actually stick a small little electron, looks like a little flimsy wire, and that area burns about the size of the white part of a Q-tip. And if placed in the right spot, it can burn the arthritis nerve. So it doesn't change anything about the arthritis. It just changes your ability to feel it. And so that works very well for folks if it's the right diagnosis. And typically, the short end, those nerves do grow back after about 6 months. I would say my average is closer to about 12 months. And so if that's ever helpful, patients can just get those nerves reburned maybe about once a year and avoid any other surgery, and certainly avoid any discomfort between months 1 through 12. So that's typically what I do for arthritis pain.
Now, off the cuff here, is there an area that you find through your clinical experience where you do an RFA procedure more often than other areas? I know you said thoracic's minimal, but how about as far as levels of the spine go, like an L5, let's say, or C7? Are there areas where you just find
Absolutely.
Where would those be, just out of curiosity?
So, I don't think it's unique to just my clinic. I think in general for spine centers, I think low back problems are probably about 75%, and maybe neck cervical issues are about 25%. And I think that just happens because of physics. Only 10 pounds of our body go through our neck, and it's easy to maybe hurt a neck doing certain things, but the other 50 to 100 to 200 pounds of your body goes through that L5 S1 junction before it spreads out through the sacrum and pelvis and then down both legs. And so by far the most common area is that level of L4, 5, and S1, kind of at those junctions in the facet joints, which take the brunt of our lumbar extension, which occurs when you're standing or bending backwards or symptomatic of arthritis.
Okay. And in addition to RFA, is there a parallel treatment option or an additional tool that you would use if you're at that level with a patient, where you would consider something else as far as that goes? And I know we're going to get into pinched nerves here, and that's I'm trying not to run into that quite yet, but is there specifically with a focus on arthritic pain, let's say at an L5, that level, and something that runs parallel to an RFA procedure that provides pain relief that's at least on par with an RFA procedure, or something else? So I want to put a pause here for just a second, because this is absolutely critical for you to understand as far as being effective treatments, and when you're dealing with pain, and we'll focus specifically on the lower back right now too, and what you feel. So another way to say what you feel would be your sensory, or what's being picked up. And I wanted to find for you, and I grabbed this from MayoClinicHealthSystem.org. What is radiofrequency ablation, or RFA for short? This is a pain management procedure primarily intended to treat arthritis or joint pain of the spine. There are small sensory nerves. Now, sensory is touch, feel, etc., not motor nerves that control movement of muscles along the joints of the spine, and the job is to tell the brain how the joint feels. Are you happy or are you sad? Now, these nerves are the primary source of pain signals coming from the joints of the back. So you hear him talking about applying this procedure, RFA, to the nerves in the arthritic joints of the back. Hang with me for a second on here because this is going to be very important to understand. Dermatomes are the areas of the skin that are connected like a phone wire for a signal to a single spinal nerve. So you got 31 spinal nerves and 30 dermatomes. The exact area that each sensory nerve or dermatome covers can be different from person to person, but there's some general really kind of patterns that fit most people. Spinal nerves help relay these information back and forth. So a skin or a dermatome, the sensory distribution of that nerve root, the numbness, the tingling within that sensory part of it are considered strong clinical clues. So I'm going to tie this together for you right now. Here are some of the sensory nerves that relate to your spine. Your L2 area, and again, if you've got an arthritic spine, listen up, that's your upper thigh, sensory. L3 is around the knee. It's quick and easy to remember, is 3 to the knee. And L4 goes to the floor or the inside aspect around the lower leg. And then L5, which is, of course, the common one that wears out. The sensory part would be on the outside part of the leg and also down the foot. So I'm not talking about sciatic here with the doc. We're talking about the sensory part. When you have arthritis of the spine, you may not have a pinched nerve. You may just have a sensory disturbance. So let's say you've got severe arthritis at L2, L3 in the lower part of your back. You've been told you don't have any pinched nerves yet, but you feel sensation differences like pins, needles, numb, tingle, and even some pain in your upper thighs and around your knees. So this question I get from people is, well, Dr. Larry, my doctor said I don't have any pinched nerves on my back. It's just arthritis. So how come I feel this sensation into my legs along with back pain? There's your explanation. It's the sensory nerves around the arthritis, and they have distinct location. So pain medicine specialists like Dr. Bruhnding utilize burning these sensory nerves to shut down the signals. And sometimes, as you hear him talk about, you get some back pain relief, and yes, sometimes the sensory relief into the leg as well too. That's why this procedure can work for some people. So next part of the interview is coming up. We're going to be jumping into some other topics as well. Stay tuned. You're listening to the Dr. Larry Radio Show. We'll be right back.
Dr. Larry will be back in a moment.
It's not too late to swap that rickety old wooden dock with a new aluminum flow dock from Jensen Aikens or Three Lakes Docks and Lifts. Quality is at the core of every aspect of our huge selection of flow docks. Stop in and design the perfect system from our in-stock inventory, and your family could have a safe, reliable flow dock system installed by this time next week. It's not too late when you choose from Jensen Aikens or Three Lakes Docks and Lifts. In-stock inventory, there's no wait. That's Jensen Aikens of Conover and Three Lakes Docks and Lifts.
Inspiration for everything I do is bratwurst. I like bratwurst. The truth is, if you take my name, Kolbis, and you put it in Polish, it means kielbasa, which means sausage. Hi, my name is Pete Kolbis, and I am the meat manager at Family Foods, but more than that, I am the best-looking person in Iron County. We love using telephone time. It's done a great job for our business. It's really created more business. It's gotten us out there further. I like working with WIKB. I enjoy our friendship, the camaraderie, and all the things they bring to the table for us. They really work with me on all different things. Buckskin Bob, everything I've asked for them has really worked out great for us. I enjoy working with them, and I'm looking forward to working with them in the future.
This is Scott from Crystal Falls, and you're listening to Dr. Larry Radio.
This local public service announcement is brought to you by Iron River Community Broadcasting.
If you're a resident of Iron or Dickinson counties and the cost of your medication is too high for you to afford, the Medical Care Access Coalition may be able to help you bring those prices under control. Call the Medical Care Access Coalition of Iron and Dickinson counties for free consultation at 906-776-5412. That's 906-776-5412.
Wesley Financial Group is not a law firm.
This story is called The Ugly Truth About Timeshare. If you think you've done your family a favor by buying a timeshare, you need my help. Hello, I'm Chuck McDowell, CEO and founder of Wesley Financial Group. 10 years ago, I started helping folks cancel their timeshare. And in the process, started what's now called the timeshare cancellation industry. Timeshare is the only thing that you can buy that you can't tell me how much it's going to cost or when it's going to end. When you buy a timeshare, you give them a blank check to fill out any amount they want for annual maintenance and assessment fees. The crazy thing is, this never ends. Even when you die, your family's now going to be stuck with this burden. Stop the insanity today. Call my office now. If we take you as a client, I guarantee we'll cancel your timeshare or you'll pay nothing.
Call for your free information kit. 800-462-3333. That's 800-462-3333. 800-462-3333.
Break's over. Time to get cracking once again with Dr. Larry.
Welcome back. If you're just tuning in, I'm interviewing Dr. Paul Bruhnding, board certified in physical medicine, rehabilitation, and pain medicine. We'll be diving into the treatment of pinched nerves in the spine and sciatica. Did you hear that, sciatica? Did you hear us? We're coming after you in this part of the interview. Roll it. Is there specifically with a focus on arthritic pain, let's say at an L5, that level, and something that runs parallel to an RFA procedure that provides pain relief that's at least on par with an RFA procedure or something else?
Yeah, so the RFA's benefit is their duration. And so kind of at a minimum, they work about 5 or 6 months. More on average, from what I've seen, they last closer to 12 months. The other analogous treatment that's actually been kind of whittled away by Medicare, and it's becoming harder and harder to do just from an approval standpoint. And I think maybe for right reason, because there's not a good it's not as long lasting, would be a steroid injection into some of those arthritis joints, not dissimilar to what you would get in your knee or a shoulder. But if you do a steroid injection into those small joints at the back called the facet joints, typically those would work for 2 or 3 months. And I think the overall literature within spine medicine, and therefore Medicare, who's making the decisions for a big majority of our folks, and then a lot of insurance companies end up following their lead, but they've started to not find those as helpful or as needed if that RFA is a viable option for the patient. And that brings up a great question, because sometimes patients aren't a viable candidate for those RFAs. There is some electrical current, some certain cardiac issues, some folks with certain already implanted devices, spinal cord stimulator. Sometimes folks have a bladder stimulator. Basically, if there's metal in the area that you need to go, sometimes that's a contraindication. So the caveat being RFAs are fairly common, and almost all folks are good candidates when they've done all the right things before that. But there's some instances where those facet joints continue to be a viable option.
Okay. Great answer. And so that does dovetail into the next section here, which is the infamous pinched nerves coming out of the neck or the back. And what a week it was this week with those, just even in my office. So I can only imagine in your office as well, too. It's a thing out there. So what I like to do is I'd like to move into, again, like you said, fancy term is radiculopathy, but pinched nerves, spinal pinched nerves. Briefly, just kind of describe to us, how does a pinched nerve, let's say in a lower back, we'll use sciatica because we all know what that is. What is the mechanism of pain? How does it cause pain? And we can use the sciatica discussion to kind of apply it to any other level of pinched nerve in general. So if you wouldn't mind just kind of focusing on that for a sciatica, how does that cause pain? How does my sciatica hurt, Dr. Larry, Dr. Bruhnding? Why does it hurt? If you can just kind of give us that mechanism and what happens.
So I visualize the spinal canal as a garden hose that runs straight up and down. And there's a bunch of different wires in that garden hose, and those are the nerves. and they travel out. It's called the cauda equina at the bottom of the spinal cord, which is kind of right in the mid part of your back, right at the level of T12 and L1. But basically, the whole lower part of your back only has spinal nerves in it, not the spinal cord at all. But they're all traveling through this tube, and often a disc bulge and or some arthritis has caused pressure on one or more of those nerves. And those nerves just function like an electric wire. And so those nerves travel from the low back, and they travel in what's called dermatomes. I pull up this map frequently. I've memorized the colors because I look at it so much for patients. But these nerves, they travel out of the low back, and then they kind of wrap candy cane style down the leg, and that's where they provide some motor or muscle control to certain muscles of the legs, and that's where they provide sensation. And when injured or damaged, that's where they can provide pain and weakness. And so in general, these pinched nerves, we think, become painful partially from ischemia. So just the pressure on that nerve, it's not getting the normal blood flow and the nutrients to the cell. And that's where, to get a little nerdy, the actual cells of the brain, the circuit of the nerve, is in the spinal canal, and then that whole nerve runs all the way down to the end of your toe, and there's no other powerhouse or no other source of nutrients. So if you knock out or injure that powerhouse close to the source, which is in the spine, then you can have pain and later weakness, numbness, and potentially even irreversible damage if left untreated for too long. That goes all the way down the leg.
Got it. And so as far as your bag of options now and what you utilize, and as far as your once you're past the history exam, imaging, you confirmed this person, and we'll just stick with the sciatica, and they've got rip-roaring pain down the leg, whether it's from arthritis or a disc bulge, herniated disc, all the above. You are now about ready to provide a treatment. What's your first line of treatment that you typically recommend for folks if it comes to something like that, sciatica specifically?
Yeah. This depends on how bad the pain is, how debilitating. And so I think in the business, you would agree, Dr. Larry, where you can call these kind of a hot radiculopathy or a hot disc. That to us says that the patient's so symptomatic and so much pain. Oftentimes, folks are coming in wheelchairs or hobbling in on walkers, or folks even go to urgent care and ER, which is not necessarily a bad option because the pain can be so debilitating from these. And so for those types of more acute pain, I certainly try to start one or two neuropathic or nerve pain medicines, but would more quickly jump to what's called an epidural steroid injection, an epidural for short. And that's to get numbing medicine and steroid onto a nerve in order to calm it down. I think about these nerves that are irritated as a swollen, like a rolled ankle. Things get red, hot, and swollen. They can be very, very sensitive. And so the idea is to kind of flood the area with Novocain or numbing medicine, and then utilize steroid to, in a more long-term approach, decrease inflammation, decrease nerve sensitivity, etc. For problems that are maybe a little less acute, I tend to more focus then on those therapy, the chiropractor. I really am a big fan of what's called nerve glides. That's a physical therapy treatment, basically trying to treat that nerve as a wire that's being pinched at one location. And you need to manipulate and move your leg or move your arm in a way that gets that nerve to move on a microscopic level and floss through the area that's pinched. That in a nutshell is how I end up treating these folks most of the time. You
just sparked a bit of interest. Roll back 1 second. What was the nerve glide therapy that you had? Was that? Did I hear that correctly? You said a nerve glide therapy for sciatica?
Yeah, nerve glides, or what's called nerve flossing. This is actually easily Googleable. It's on YouTube. There's all types of.
We can Google it.
Videos.
Okay, so
you can Google it, Dr. Google. Yeah.
Yes. So in a nutshell, the nerve glide therapy, just kind of repackage that up again and explain what the concept, the theory is, and what you're trying to accomplish for nerve glide therapy on sciatica.
Sure. So in our low back, a nerve is pinched, perhaps from a disc bulge. And so picture that garden hose again running up and down the back, and there's a bunch of nerves that are a bunch of wires running up and down through that. There's a disc that's pushing on one of those nerves, and that's causing that pain all the way down the leg. And so there's a pinch point on that nerve. And so the goal is that nerve runs all the way from your low back, and in some cases all the way down to your great toe. And in some of us, that can be 3, 4, 5 feet long, just about. And so the idea is to treat that nerve as almost a piece of floss, and trying to manipulate and move your leg and stretch the buttock and the calf and the ankle in order to get that nerve to move even on a microscopic level, but to wiggle back and forth between that pinch point and hopefully alleviate some of that ischemia and constant pressure, and hopefully alleviate that pain into the leg. Sometimes it's 100% helpful. Sometimes it's 10% helpful, but I think anybody who's had this type of pain would say, I'll take anything. And that's a free treatment that you can do yourself, and oftentimes works fairly well.
So for theater of the mind, folks, what Dr. Bruhnding was just saying here is, yes, Google it for sure. But as far as your concept, think of you are trying to maneuver the sciatic nerve, not necessarily your back or spine. Obviously, sometimes where it's coming out of the exit point there, especially in arthritic conditions or herniated discs, the wiggle room can be tough. And so what he's saying is that to kind of reposition your thinking and just manipulate using buttocks, leg, even like oscillations, things like that, just to try to get, just even like you said, on the small scale, that sciatic nerve to start to manipulate a little bit, rotation, side to side, whatever it is. Because if so, and if you can get to move or wiggle a little bit, you're going to start to increase or decrease some pain and increase the therapy as far as it goes, even before you see a practitioner. Interesting way to say that. I hadn't heard that term coined like that, but I understand what you're saying. To go back 2 steps further before we tie up the show here, how do you, as a practitioner, when you are doing an epidural steroid, is there some type of technique or some type of visual? How do you know where to target the medication to be at its most effective area? I mean, is it, for analogy, like a carpet bomb kind of thing, or are you really trying to look at where to go and target versus just kind of run the path of just dousing it with medication? How would you describe your ability, not an ability, how would you describe your technique to target the area correctly? Nerve gliding. Nerve gliding. I never heard the term before. From verywell.com, I went to Google, I searched it. Here's what nerve gliding is, also called nerve flossing or neural gliding. It's an exercise technique used in physical therapy to improve the way your nerves move and reduce pain. Nerve gliding exercises, and you can do this, by the way, not just for your sciatic nerve, you can do it for your ulnar nerve, may be used as part of the recovery process for certain conditions that involve any nerve tightness or nerve tension. So if you've ever blown your sciatic nerve before, when you like tilt your head down, all of a sudden you feel tightening across your back, maybe even your leg. The nerve is tight as well too. So, of course, this could include muscle strains or sciatica from a pinched nerve. Now, depending on your specific needs, nerve flossing exercises may focus on upper or lower extremity nerve gliding techniques. And they can also be used as kind of ways to promote flow in the continuous and repetitive motion sort of way that the nerve gliding does. And the most common nerves that require nerve gliding rehab include the radial nerve, median nerve, ulnar nerve, and that's in your arms as well. And then, of course, the sciatic nerve, which is kind of our focus today. Nerve flossing is a gentle way to soothe compressed nerves and regain range of motion, especially when combined with traditional physical therapy. So I've been in the healthcare and working on nerves for 20-ish years. And this technique, I never knew the label to it. It's something that over time I found to be very effective, called nerve flossing. So Google it. I Googled it. Now, thankfully, it's a technique that I've been utilizing for many, many years, is the short, little, small movements along the path of the nerve to help regain range of motion. More so than just doing a full-on heavy stretch routine. And because the heavy stretching to try to stretch the nerve out, you know what happens sometimes. It feels good while you're doing it, and all of a sudden you pay for it afterwards because the nerve just completely explodes on you because of the pain. So the nerve flossing is gentle gliding of the nerves. Keep that in mind. And if you got any kind of nerve problem right now, lower extremity or upper extremity, Google it, look at it, and start applying some of those techniques. Oftentimes a lot more effective, as you heard Dr. Bruhnding say, than some of the more aggressive stretching. That's my add-on as well, too, that I've seen clinically. Okay. Also, you heard him discuss the sensory nerve thing, like I think he said candy cane, sort of down the leg. Nice little theater of the mind there as well, too. So we both kind of dovetailed and tag teamed together that discussion about sensory nerves. Again, building blocks of knowledge for you as well, too, to help you understand, because nerve pain can be really, really tricky. All right, our final segment of the interview when we get back from the break. Stay tuned. This is the Dr. Larry Radio Show. We'll be right back.
We'll be right back with Dr. Larry. We're back with Dr. Larry.
Class is still in session. Pull out your pocket protectors, pencils, pens. We're finishing up our interview. Roll it.
Yeah, specific, very, very specific. I think, I mean, it'd be like sighting in a rifle where you know exactly where you need to go. Often, I almost never do an epidural without having an MRI to review, just because you want to make sure that between the skin and the target, you know, every single thing, every single layer that's between that nerve and where you need to go, and so that you can get there in one smooth path. And we do these injections under x-ray. Usually they take between 5 and 10 minutes or so. People are laying on their stomach. And I talk to you through the whole thing and usually tell you boring stories about my kids, or we talk about the weekend and stuff, trying to kind of keep the mind off what's going on. But very specifically, I have that MRI visualized in my mind because x-ray only shows the hard tissue, such as bone. And from there, I can extrapolate where the soft tissue, such as the nerve and the disc or other issues are. And we use a contrast dye, which is iodinated. And if folks have an iodine allergy, we can use another one that doesn't have that. But basically, that dye then confirms where I've put my needle on x-ray, and then using multiple different views in order to triangulate where exactly that needle tip is. Then the numbing medicine and steroid goes there. And so when I've talked to folks in the clinic, we've done the physical exam, I'm looking at their imaging with them. Right there, I'm already formulating what's going to be the best place. I usually try to get within, depending on certain pathologies, I can get it right to the pathology. And if it's a disc bulge, maybe right in the center of the spine, I can get within a centimeter or a centimeter and a half of where I need to go. But basically just always trying to go as close as possible to the problem so that you get the biggest bang for your buck.
That was a golden nugget I was looking for. You nailed it. So you take obviously the exam. You've physically examined them. You take the MRI, looking at the layers of tissue, and then in combination with what you've got logged in from the MRI, then you have your X-ray video you're looking at, and so you're combining hard tissue, soft tissue, and then also my final question would be: is there a certain level of tissue resistance when you're applying the medication or getting the needle, let's say, to where it needs to go? Are there different ways as you're talking to the patient, like you're walking through, where you find it can be easier or less or more difficult to navigate based on certain patients and problems?
Yeah, it's going to sound weird, but different tissues feel different when you put a needle through them. And so picture pushing a needle through a steak versus pushing a needle through yogurt. I mean, the amount of resistance on that is different. And I've just done enough of these where I really have a good feel for where I'm at in space. And then we're always using the x-ray. So this is done with an x-ray that's in the shape of a C, and you can maneuver that x-ray in a 180 degree pattern in order to take a straight AP or perhaps a lateral, but always checking and making sure that you're at a safe depth and knowing exactly where you are in space. And so it's a combination of those two, feel and visual.
Excellent. And it kind of, to draw us back to an aerial view, how we started the show. Your training, your double board certification, being a DO as well too, and now doing pain management and specifically the type of conditions you treat. And then drilling it all the way down to the most ground level. When you go to inject a needle, you are combining the holistic approach to the person, the tissue resistance, the depth, the angle, and combining imaging together with patient presentation to effectively deliver the medication in the right area. And it's called the art and science of being a doctor for what you're doing. And if you can combine both brains, both the science part and the art part, and merge them together, those types of practitioners have the best types of outcomes. Even if we can't fix everybody, or even if you can't fix everybody, the point is that you're going to have a higher degree of success because of combining those two parts of the brain together. Purely scientific vote's great. You can't be purely all art. You got to have science behind it. But if you combine those two, and it makes perfect sense. And like I said, you pulled out the gold nugget. I was hoping that you would, and it kind of ties it all nicely together. Dr. Bruhnding, thank you again for coming on the show. If listeners want to contact you for an appointment, they've got arthritis, they've got spine pain, and then you were in some type of patient care procedure before we got on the air today too, and that caught my interest, but it wasn't the focus of the show. So I kind of had another section of a show I was going to ask you, but what is the phone number that folks can get a hold of you at, and also the website as well too? People like to hop on the website and take a look at stuff.
Absolutely. It's been a pleasure, Dr. Larry. Thank you for having me. Our number down here at OSMS, which is Orthopedic and Sports Medicine Specialist, is 920-430-8113. And our website is OSMSGB, as in Green Bay, OSMSGB.com.
Okay. Once again, folks, this is Dr. Bruhnding from OSMS, and board certified pain management and physical medicine, rehabilitation, doctor of osteopathic medicine. Thank you for coming on the show. We'll have to do this again at some point down the road.
Absolutely. I'll be here. Take care, Dr. Larry.
Thank you.